Good morning, everyone. Um, I'm here today to present our report on our procedure about dog castration. And this is from Group 3. I am the surgeon, Tricia Joy J. Marzo. And like a Sobrevilla is the assistant surgeon. We have our nurse, Gladys Claire Cariaso, and our anesthesiologist, Etheline Canero. So for the signalment, we have here our patient. His name is Nico. He is a dog. Um, he is 7 months old and he weighs 8 kilograms. A male, of course, because this is for castration. And he his color kind of looks like a husky. We have white, black, and gray in him. So for our indications, we are doing this procedure called decastration to reduce overpopulation of dogs because after castration, the dog will not be able to reproduce anymore. And then we need to in order to reduce the overpopulation of dogs, we need to inhibit male fertility, and castration is the way to do that. Is one of the ways to do that. I mean. And then we also need to do castration on dogs, on male dogs, to decrease male aggressiveness. So as we know, during mating, when there is a female dog in estrus, the male dogs usually gather around and they tend to fight for a chance to mate with the female. And during this time also, they they roam a lot. I mean, especially during the hot season when the female dogs um are usually more um especially during the hot season or the summer, they tend to be in heat. Many female dogs tend to be in heat during those times. So the male also tend to follow those um, in heat females, and it causes them to just roam around the environment, especially if they aren't um, caged or if the owners just let them roam around. And this can also lead them to be lost, especially if they aren't familiar with the environment that they are going in. And then castration also prevents undesirable urination in male dogs. Again, when during a mating season, these dogs tend to urinate in different areas, especially in the places near um or in the environment where the females are found. They tend to urinate around those areas, and it's not just like on the ground or anything. They tend to urinate on chairs or on trees or whatever it is that they can mark. And then that leads to prevent marking of territories. Since they are males, they tend to fight for territories. I mean, females do that too, but males probably do it more during the mating season again. So those are the indications. Now let's proceed to the anatomy of the male canine. So we have, as the first part, we have the scrotum of the male dog. So the scrotum is the outer covering or the skin that surrounds the testis. And then we have the testis. This organ is inside the scrotum. And this is where the testis is oval and round in structure. And they produce this sperm. Then we have the epididymis. And The epididymis have a tail and a head, and um, this is where the sperm completes its development. Oh, and then we have the ductus deferens or the vas deferens, and um, then we have the spermatic cord. And then now we go to the preoperative preparation. Of course, we fasted the patient, Nico, for around 8 hours. And then um, we prep him by exercising him probably an hour before the surgery, and then we cleaned his skin, especially the part surrounding the scrotum and the scrotum itself. And then for the surgical positioning, he was in a dorsal recumbency. We also put IV fluids to make sure that he is hydrated. And then for our anesthesia, we had atropine sulfate for our pre-anesthetic and zolotil for our anesthetic. And then before the procedure, the anesthesiologist took his vital signs, the temperature, the respiratory rate, and the pulse rate or the heart rate. And then we proceed to the pictures during the time when we did our preoperative preparations. And there is our nurse clipping the hair in the scrotum and around the scrotum. And Ethylene checking the vital signs. And there is also another picture of ethylene injecting probably the atropine sulfate or the zolotil. Next, we go to the operative technique. So we did an open prescrotal technique. So for this procedure, we use a scalpel holder number 3 and blade number 10 to incise the skin and the subcutaneous tissue along the median raphe. So the median raphe is the area in the middle of the scrotum that divides the right and the left part. And then we continue the incision to the spermatic fascia to exteriorize the testicle. And then we incise the parietal vaginal tunic over the testicle, but not the tunica albuginea. And then we digitally separated the ligament of the tail of the epididymis from the tunic. So now we have to, after that, we individually ligated the vascular cord, on which is where the blood vessels located, and then we also ligated the ductus deferens. This is the part where the sperm will travel during ejaculation of the male, and then we ligated both of those, and here we did two ligations for each, and then another two for both, like and then we use a number two ceramic catgut suture to ligate the parts. And then we next grasp the ductus deferens with forceps over the ligature and transact both the ductus deferens and vascular cord. Yeah, and then after we ligated those, we need to inspect if there will be hemorrhage. After that, we also need to ligate the cremaster and the tunic. We also did two ligations there. And then after the ligation, we need to cut those organs, remove the testicles and the epididymis and the testis, the epididymis, a part of the vascular cord and the ductus deferens. And after ligating the cremaster muscle, we also cut the part after the ligation. And then we advance to the second testicle into the incision, incise the fascial covering, and remove the testicle as described, just like what we did on the first testicle. Next, we go to the closing. We close the subcutaneous tissue with 3-0 monofilament chromic catgut suture using a continuous suture pattern, and then we oppose the skin with an with an external simple interrupted suture pattern on the skin using 3-0 silk suture. For the post-operative technique, um, I gave Nico food and water when the anesthesia wears off, and that's around the afternoon or maybe nighttime already. And for the first 2 weeks, we need to minimize his exercise. So he only goes on walks when he wants to pee or when he wants to poop. And we use sulfonamic acid as an analgesic and anti-inflammatory medicine. He doesn't like the taste of this one, so after 3 days, I switched to himperin, and then we had cephalexin 250 milligrams as our antibiotic given 2 times a day in the morning and in the afternoon after Nico ate, and that was done for about 10 days. And the wound is cleaned 2 times a day with chlorhexidine solution, also in the morning and in the afternoon. And after cleaning, mupirocin ointment is put on the wound. And then we also put an e-collar on Nico's neck to prevent him from licking his wound because that will cause an infection. And the suture was supposed to be taken out after 7 to 10 days, but Nico took those sutures out himself on day 5, I think, because he managed to remove his e-collar on his own, and that's when he removed his sutures. And we have here a video of Nico 3 weeks after castration. He's all healthy and well and already active and playing. So that's him happy and having fun. So next we go to the complications. So what are the things that can happen after the dog is castrated? So one of those is that scrotal swelling and bruising can happen. So this happens if the there since that is the scrotum is not removed, only the testis inside them, um the body views it as an open space or an empty space, and so it tries to fill it up with fluid to make it look like there's something inside it, something like that. And then we have hematoma or seroma, just like the explanation on swelling. Oh wait, so actually no. For this scrotal swelling and bruising, it happens after the procedure since there is a wound. Inflammatory cells tend to migrate on that area and it causes the swelling. And it's normal because there's a wound in there. And then we have the hematoma or seroma. Hematoma happens if the blood vessels are not ligated properly during the procedure, so the blood can leak and pull into the scrotum since it's an empty space. And if that's not the case, seroma can also happen. So in seroma, fluids from the body can accumulate in the scrotum since the body views it as an empty space, that is. And also infection or the presence of pus. So this happens especially um, if the animal licks the wound on the scrotum. So that's that creates a perfect environment for bacteria to grow. And when that happens, there could be pus. So that's why we give the dogs antibiotics. And wound dehiscence can also happen. Um, during wound dehiscence, the wound or the incision takes longer to heal, or it could not heal properly, something like that. And then we go to the drug complications. For our atropine sulfate, um, we we have here our dog, which is 8 kilograms, and then we multiply that with 0.044 milligram per kilogram divided by 0.65 milligram per ml, and we injected him with 0.54 ml of atrocyte. And then after that, we have our anesthetic Zoletil 50. We injected it via IM. So we have 8 kilograms times 10 milligram per kilogram divided by 50 milligram per ml. And we have 1.6 ml. Tranexamic acid. Um, so we multiplied his weight with 10 milligram per kilogram divided by 100 milligram per ml, and we injected Nico with 0.8 ml of tranexamic acid and 0.4 ml of tolfenamic acid. And for our IV fluid computations as maintenance need, we gave him 800 ml of lactated ringers D5 LRS. And then for the fluid loss, we computed about 400 ml, so the total was 1,200 ml. And the drip rate for this during the procedure and the following hours after that is 1 GTTS per second, or 1 drop per second of the IV fluid or the D5 LRS. And that's all for our report. Thanks for listening.